We got about 30 minutes here to do hand and wrist, which is not really enough, so we're going to have to giddy up and go. So let's do it. So hand and wrist injuries, really common. Let's be clear about this, that the hand anatomy is complex. That's why after you do 5 years of orthopedics, if you want to do a hand fellowship, it's an additional 2 years still. Unfamiliar injuries which occur there are often unrecognized. Ligamentous injuries are unrecognized because the exam is difficult. Alcohol intoxication is pretty important in falls. So we talk about a foosh, fall on outstretched hand. And there's lots of reasons to fall on an outstretched hand. You trip, the uneven floor surfaces. But one of the other main reasons for falling on an outstretched hand is you're drunk. And other things like that, which makes it tough. They're not so cooperative with the exam when that's the case. Some difficult injuries are only found through wound exploration. And, wound exploration requires time, patience, and a knowledge of the anatomy to find those injuries. And so this is a challenging area. We haven't even touched on the fact that peds and adults are different because in pediatrics you got open growth plates, so you have all the Salter-Harris things coming to bear as well. So when you're talking about fingers, I see this all the time on charts. People tell you, the second digit, the third digit. Please don't do that, because then I got to figure out what part of the world you're from. Because in the United States, we're #1. In France, I'll have 1 croissant, and in China, I'd like 1 durian. So I don't have to, don't number fingers, name them. It's thumb, index, long, ring, and short. Don't say medial or lateral. Say radial or ulnar. Say dorsal or volar. And then describe things with their relationship to the joints: DIP, PIP, MCP. There you go. When you do a chart on an upper extremity injury, all charts on upper extremity injuries, regardless of the template you have, and we have templated electronic medical records, all they are is encouragement to bad charting. But a hand history starts the same way. 35-year-old right-hand dominant carpenter presents with, I need the age, the hand dominance, and the occupation. That's how it's done. These are sensory innervation of the 3 nerves going to the hand: ulnar, median, and radial. The detail of the exam of those sensory components depends where and what the injury is with regards to how specific you need to be. In terms of motor, the median nerve is the tea drinking nerve. That'll help straighten it out for you if you can remember that. Flexors, notice it's the pincer grasp of the fingers, making the 6, which is the 6th nerve, the dominant portion. Pinch your tea glass, flex at the wrist, flex at the elbow, and pronate to take a sip. All of that is median nerve. The ulnar nerve is pretty much everything in the hand. It's the intrinsics. And the radial nerve is the extensors. And radial nerve injuries may occur, as can the ulnar and median nerve, at a variety of levels. But when you're looking at upper extremity injuries that are proximal to the hand and wrist, remember, you want to document that those 3 nerves got past the injury site, if it's a laceration or a fracture or things like that. Flexor tendon anatomy, remember that there is both a flexor digitorum profundus and superficialis, and you need to check both. The fact that a person can flex a finger doesn't mean both of them are intact. It means that one is intact, so you have to isolate them. That's FDP, I'm isolating FDP, and if I check rein 2 fingers and hold them back, I'm now checking FDS. Okay, so you got to check for both. And you can see that there's a fairly complex thing there where, for example, the distal portion of FDP can be pulled off as it goes to the fingertip. That's a so-called jersey finger, and a variety of other injuries that occur with these. And here you can see some of those things outlined. So flexor tendon anatomy, again from the side, you can see all of these vinculi, which are the bridging items to them. And we've already talked about FDP and FDS there. And here we see the outlining of FDP and FDS testing. And when you have a hand injury, particularly on the palmar side or the volar side, you want to document that the flexors are intact. Wrist is even more complicated than the fingers, because the fact that someone can flex their wrist doesn't mean that a wrist flexor is intact. All the fingers can help you flex your wrist because they go past there. So you have to get very specific with these exams. Here again is a little table with the basic nerve function, and these are really worth knowing about. The next nerve that we have to talk about is the $1 million nerve, which is the recurrent median nerve, which branches off the median nerve right at the flexor crease and goes to the base of your thumb. So when someone falls on a piece of glass and has a laceration right at the base of their hand and their thumb, you're trying to figure out if that's working or not, you're talking about the recurrent median nerve in that setting. Here you see some fingertip fractures. This is a really common injury. Tough fractures, closed in a door, dropped on a heavy object dropped. There'll be subungual hematomas, and there may be lacerations of the nail bed beneath the nail plate. If they're open, we usually treat these with antibiotics, although there's some papers that say it's not that important. I still think most do. And if they're intra-articular, if they go all the way through the finger into the DIP joint, then they probably ought to be referred because they're at risk for substantial DIP arthritis if they're intra-articular, post-traumatic arthritis. Splint these for protection, and they need pain meds. One of my pet peeves with the residents sometimes is they'll place them on Motrin. One, that's a bad idea because Motrin is actually an anti-bone healing drug. You need inflammation for bones to heal. So giving an anti-inflammatory to a fracture is like, let me give you a drug that'll prevent your healing. That's not so smart. And secondly, it's just not strong enough. When people want to treat this with Motrin, I want to take their fingers and hit them with a hammer and then ask them afterwards if they think a Motrino will fix that. Motrinos are for people you want to fill up the outer electron shell. You know, they're down a Motrino, you give them a few Motrino pills, and then the electrons and the neutrons and the Motrinos are all balanced. Mallet finger or baseball finger is an injury to the distal extensor tendon insertion. You get this little swan neck thing. Down the bottom is shown the splint to splint it up and a little bit of hyperextension. Don't be too forceful with the hyperextension. You can actually get a compartment syndrome or a felon of the distal finger. Now the bottom x-ray there shows a mallet finger with a large fracture component where the extensor tendon is attached to that. If a fracture fragment was that big, you should have a low threshold to refer these. A fair number of hand surgeons, naturally based on their insurance status, will pin those with a small K-wire to get that to heal. You all know what it's like to find a hand surgeon for someone who doesn't have very good insurance status. Usually to get one in that setting, you need like search dogs and a helicopter with a FLIR system over a gated community, binoculars, those kinds of things to find a hand surgeon for those types of patients. If some of you out there know hand surgeons or are friends with them, you know it's true. All right, so subungual hematomas, you'll hear these things, oh, they should be drained if it's a half or a third or some magic number. I think the magic issue here is if the patient knows their pulse, they hold up their finger, and you say, what's your pulse? And they go, boom, boom. That's what you feel in your finger, then you should drain that. And you don't need to get a lot out. You can use one of those red-hot nail trephinators, you know. If you're looking for that, it's out on your ambulance ramp. The nurses are using it to light cigarettes. That's where you'll find it. But if you don't have one of those, you can spin an 18-gauge needle until it'll carve out a little hole and you'll get these drops. People sometimes worry that you're converting it to an open fracture. As we indicated before, even open fractures, some people say don't need treated with antibiotics, so I don't think that's a big issue. And as I said, this is debated. I generally do treat them with antibiotics if I think it's open. Nail bed repair. So here's a picture showing some nail bed injuries. The International Nail Bed Classification System divides the nail plate into 5 zones. I think that's a little crazy. More common parlance is to talk about 3 zones: the very distal portion of the nail where you can just trim it back, the middle portion where you should consider removing the nail so you can get at the injury underneath, and then the base where the germinal matrix is, which is of importance because sometimes the nail won't grow back. Fine absorbable suture, you want to restore anatomy. What does the literature say about the restoration of this anatomy and what you're doing here? Pretty consistently it says less is more. You can turn this into some gigantic shop project where you stuff, you know, zero-form gauze in or a little foil from the suture package, things like that. You could do all that, but most of them say do as few stitches as possible to restore the anatomy. Put a big glop of triple ointment on there, some polysporin or whatever it is. Put a non-adherent dressing on it and splint it and call it quits. Nail regrowth is slow normally, but if there's injury to the germinal matrix, it's slower still. This might be a little too much information, but when I played soccer at McGill up in Canada, we played on AstroTurf, and you know, one of the things that happens to you when you play soccer is people step on your feet, and they step on your feet with spikes, and that hurts. And so after about 1 year of soccer on a hard surface like AstroTurf, I had no toenails left, none. And then they didn't grow back. And so at the end of my college career, I was like, okay, I'm gonna be the mutant dude that's afraid to take his shoes off on the third date, because I'm gonna have these toes with no, and about 8 years later, one day I was in the shower and I was like, hey, look at that. Little nubbin of a toenail. And then they all saw, it was like they all decided at once, all right, we're growing back. And so within about 3 months, I had 10 toenails again. So I was very impressed. It was like, I had kind of given up on them. It was like 8 years that I didn't have any. Trigger finger, remember that flexor tendons have high forces on them, and that's why we don't repair them as opposed to extensors, which have low forces on them, which you can repair. The other reason you don't repair flexors is because they have to go through A and C pulleys or multiple pulleys. And so if there's any knot or inflammation or a little bump on a flexor tendon, when it comes through one of the pulleys, it can get locked on the other side, and that's a trigger finger. DIP and PIP joints will stay flexed. The patient will click. Sometimes they can unclick them themselves. It's a pretty straightforward problem. I'm sure all of you have seen it, know someone who has it. Treatment is activity moderation, NSAIDs and splints, and ultimately after therapy and steroid injections, which I think in this case steroid injections probably are the domain of the specialist. I think injecting into tendon sheaths or around tendon sheaths, not particularly a good idea because they'll rupture. And then the radiographs, of course, will be negative because there's nothing to see. This is all a soft tissue component. Pretty common problem, oftentimes very frustrating for patients. This and ganglion cysts are pretty common reasons to be referred to a hand surgeon. And if you have sort of an HMO kind of insurance, a lot of times they try and delay you and try and get you to go. There was an embarrassing memo from Kaiser at one point between two Kaiser executives where they were discussing things, and one was discussing with the other and pointed out, well, someone stays with Kaiser an average of 2 years. All we have to do is delay their hand surgery for 18 months, and then it will be the problem of their next HMO or the next person covering them. And so a lot of patients have gone through these frustrated delay things when it's pretty problematic for them. All right, paronychia is the superficial infection at a nail bed that just needs drained easily and doesn't need antibiotics. Drainage alone is adequate, and that's the picture on the right. And then the felon is the true pulp space infection, which is sort of the picture on the left. Those need to be drained through and through. They're more serious, and they do need antibiotics. So the felon is this more serious, complete pulp space infection at the distal fingertip. And here you see the paronychia being elevated, and you can IND them from along the nail plate as shown there, or if they're pointing clearly, you can just do a stab incision of them. Don't do a stab incision of this. This is herpetic whitlow. It might look like a paronychia, but you see there's some little bit of vesicular component to it, because if you do a stab incision on this, you might result in herpetic tendonitis or herpetic myositis, which will hurt for a long, long time. You might want to pay attention to the history of this. A bartender that keeps sticking their fingers into glasses with backwash from people's mouths, or someone at daycare who keeps putting their fingers and cleaning, getting things out of children's mouths and things like that. That's who gets this. It's HSV1 usually, acyclovir for treatment, no IND. If it's superficially infected, you can add antibiotics, but these look pretty bad even without superficial infection, and acyclovir is where you should go. FTS, flexor tenosynovitis, bite, splinter, puncture, cat bites in particular, violates the tendon sheath, and then you get canaval signs, which are fusiform swelling, pain with passive extension, pain with proximal palpation of the tendon sheath, and a flexed posture at rest. You'll notice that a red digit is not one of them. On exams, they tend to ask you that, if redness is one of canaval signs, and it's not. This is a surgical emergency. It needs to be decompressed. The surgery is fairly significant. It almost always will require a hand surgical specialty, so these are things that get transferred. They need to be elevated in the interval, antibiotics started, but without treatment, these will progress and have serious problems. Boxer's fracture. Obviously, it's not a very good boxer. Boxers don't hit you with their small digit. They hit you with their index and long finger MCP joints. There may be an open MCP joint there, and you got to worry about that if it's a so-called clenched fist injury, because if it's a mouth bite wound, you got to treat with the appropriate antibiotics. and broaden the spectrum to cover that. You want to make sure there's no extensor tendon injury, although those are relatively rare, because the extensor tendon flares out as it goes over the MCP joint, so it's hard to get the whole thing lacerated. Rotational deformity of any metacarpal fracture is not acceptable. And for a boxer's fracture, what's the acceptable angulation? It's 40 degrees. So if you're looking at your fingers, acceptable is 10, 20, 30, and 40 degrees of angulation. And any Canadians in the house? The Canadians are a little more conservative in the back. It's 10, 10, 20, 30 is sort of the Canadian standard. I don't know what manual labor they do that requires a more conservative management, but that's generally the stated rules. These can get placed in an ulnar gutter splint. You can do a hematoma block on them if you want to try and reduce them. You can do an ulnar nerve block if you want to try and reduce them. The fact of the matter, though, is that you go to all that trouble to reduce it, but the flexors are stronger anyway, so they pull it back off. And it's very hard to keep it reduced. Even if you build a beautiful ulnar gutter splint, it rarely stays. And that's why most of the European literature says, the hell with the ulnar gutter splint, just put it in an ACE wrap and tell them to go back to work. It's their approach. That's socialized medicine. Here's just looking at various sites and problems with metacarpal fractures. What you really do need to know is rotation unacceptable, and anything that allows it to shorten and go towards the flexor side generally will occur because, as I pointed out earlier, the flexors in the hand are all stronger than the extensors. So if it can be pulled off and shortened on the flexor aspect, over time it will. And so they often need to be pinned. The Boutonniere deformity. Central slip extensor tendon is disrupted and it pulls it back into the side as shown in the diagram below. The lateral bands pull it back. These often need operative repair. Sometimes there's a fracture with them, and the fracture makes it easier to repair them than when there isn't, because again, the fracture can be pinned down to take advantage of bone healing. Proximal thumb fractures, these are worth knowing, and people often ask me when they're relatively new or coming into emergency medicine, you know, the eponyms of the fractures. Do I got to know a Rolando's and a Bennett's and a, you know, the list goes on and on and on, a Jones, a Dancers, and these, and the truth is, no, you don't need to know the eponyms, but it certainly makes it a lot easier to discuss with your consultant if you do, because you don't have to spend a lot of time trying to describe things over the phone. You can say, you know, I got a Rolando's or a Bennett's, and it'll be clear. Now, Bennett's almost always needs ORIF, but technically that's the difference. Rolando's definitely always needs open reduction and internal fixation. The Bennett's you can try and reduce and put in a thumb spica cast, but because, again, the base of the thumb is not a long enough bone to really effectively pry a cast to hold it, it often comes apart, and in reality, both of them often need to be pinned. You can see in the Rolando's where the base of the thumb is shattered, there's no way to do that but to put it together, and this kind of shows you which pin they want to put in first. Gamekeeper's thumb, a non-bony injury usually. There can be an avulsion fracture. Here's the exam shown to you in the picture. They have laxity and focal pain. This is skier's thumb as well. Gamekeeper's thumb, all refer to the same thing, and they'll get this laxity pattern there that's very painful. If you don't fix it, that laxity will persist, and the person won't be able to do some pretty common tasks, like they won't be able to open a jar of mayonnaise ever again with that hand. We don't have to get into all the injuries that we're talking about that I've had, but I've had a lot of them. But here's the result of my skier's thumb. You see how this hand opens up so much bigger than the other one? So for me, it's sort of a success because I can palm a basketball, which I couldn't do before. I still can't dunk or play basketball. That doesn't matter. I can just stand there like this. No, really. What? Then I have to give the basketball to someone who plays. So for me, I think that's a successful outcome, but I can't open mayonnaise. So there you go. But you'll get that laxity with that. Carpal tunnel. This is one of the most common work-related cumulative trauma or repetitive stress disorders. It's often contentious because someone says, oh, I don't think it's carpal tunnel, because there are other disease entities that are associated with carpal tunnel, rheumatoid disease, hypothyroidism, diabetes, a variety of other things. And so it's sometimes contested. The carpal tunnel, as you see in this cross section, gets crowded and the nerve gets compressed. And they might have a Phelan's test that's positive, or a Tenell's test that's positive, or a median nerve compression test, or a modified Phelan's. There are a variety of clinical maneuvers. The recent one that's most in vogue, if you wanted to talk about it, is the modified Phelan's, which is where you do the Phelan's test and you add 2-point sensation to it after they've been in the position for a little bit. Wrist splint, NSAIDs, refer. Sometimes the tunnel needs to be opened up and decompressed for them to have relief. All right, now, falling and outstretched hand can give you some pretty subtle injuries, and you got to be careful calling things wrist sprains because they may be more significant injuries than that. And the most common missed wrist injury is a scapholunate dissociation, where someone doesn't appreciate that ligament's been completely torn. There are other things that you don't want to miss, like a scaphoid fracture and things like a triquetral fracture, and we'll get to those in a moment. So scaphoid, you don't want to miss it, and the reason you don't want to miss it is not that it's any worse than any other bone in the wrist. They're all pretty important, but this one tends to get avascular necrosis. So missing it leads to non-immobilization, and that non-immobilization is then blamed for their ultimate AVN and post-traumatic arthritis. And so it is the most sued of the scaphoid, of the wrist injuries. And so the characteristics are snuff box, tenderness, pain on axial load, tenderness at the scaphoid tubercle. That's right here if you come in at the base of the thumb. I'm now pressing on my scaphoid tubercle. X-rays are non-diagnostic, and a quarter of the time, even when you get a scaphoid series. So if you clinically suspect it, they should be placed in an immobilized with a thumb spica splint, and technically it should be a long-arm thumb spica splint because a short-arm thumb spica splint still allows them to supinate and pronate, and supination and pronation has been proven to show movement at a scaphoid fracture, which you're trying to avoid. There's the snuff box tenderness. Really, once you see the snuff box, that's not enough. You should only deviate them and put them neutral, which is actually about 10 or 15 degrees flex. That brings the scaphoid bone into the snuff box for you to feel it and see if it hurts. Scaphoid tubercle shown there, that's the test that's used in the European literature. And then there's also axial loading, where you just bear down on the thumb, push the thumb down towards the scaphoid. There are a lot of options here. You could do the plain films and see if you find it, and most people start there. And then if you're really worried, you could go straight to MRI to identify it. That's obviously going to be expensive, require some explanation. Some people say that's better than being placed in a cast for a week. You know, they'll look at you, doc, I got a job to do. I need to know if this is broken. So there might be sort of economic considerations. In other countries, it's been seen to be reasonable to put them in a splint for a week and then re-examine them and re-x-ray them in a week. That's the cheapest option, depending on what their lost work productivity is. There's all kinds of detailed economic analyses here. You'll figure out very quickly what your institution traditionally does with it, and generally speaking, I would stay with it. Look for other associated fractures like the radial styloid, ulnar styloid, distal radius fracture, etc. So here's a typical scaphoid fracture at the arrow there, right through the waist. And what you're worried about is the proximal portion of that bone, which is the largest articular surface area of the wrist, dying. And the reason it might die is because the proximal surface of that bone is in the distal circulatory bed of bone perfusion, because the deep branch of the radial artery has to do a U-turn and then run retrograde through the scaphoid. All right, scapholunate dissociation, like the Terry Thomas sign, or you can get a little more modern and talk about David Letterman. And what you're looking for is a gap between the scaphoid and the lunate. And here you see with the red arrow pointing to a really obvious one where it's greater than 3 millimeters. But you ought to be able to examine these as well by jumping off Lister's tubercle. If I'm on Lister's tubercle, which is the dorsum of my wrist right here, and I slop down into the wrist joint, I'm right on the scapholunate joint. So tenderness at that point, even if it's not 3 millimeters separated, would alert you to the fact that this might be there. And so these need a thumb spica cast or splint for 6 to 8 weeks, and a lot of times they need surgery. This one, I can tell you, with that huge gap there, probably needs surgery. And then we have the lunate and the perilunate dislocations, almost always a foosh. These are bad injuries. Both are surgical. You know, it says emergencies. I'll say quasi-emergencies. These are really, they're dislocations. So they, you know, you want to get them back soon, which means usually admission and orthopedic involvement. This is also an image showing scapholunate dissociation. The pen tip is on Lister's tubercle, and it's showing you it's right over the scapholunate joint. That probably should have been a little earlier. Splinting the hand and wrist, you can put them as shown here. This is the position of function, right? You know, how you'd hold a beer can, is talked about. And that type of splinting is totally fine for short-term splinting. 3, 4, maybe 5 days at the most. If you're going to splint someone for longer than that for a known tendon injury or repaired tendon or a fracture, then they should be put in this position. Wrist cocked up, this at 90, and this joint, the PIP at 180. That's called the blade of the hoe. I know we're in Las Vegas. Hoe, H-O-E, like garden tool. Blade of the hoe, okay? And if you want to talk about it a little more technically, it's called the intrinsic plus position. And that's a better way to splint someone for long term. All right, a little bit about digital nerve blocks. You can use lidocaine, you can use bupivacaine. The sensory nerves, here they are shown on the side of the finger. And there are other ways you can go about this. You can do a web space or a transthecal block. And you can also use bupivacaine, 1/4 or 0.5%, which is going to last longer, which might be important. Like, for example, if I'm going to do a digital block on someone who needs their nail bed taken off, who's got a crushed fingertip, that hurts a lot. I'm going to use bupivacaine. Why wouldn't I give them the benefit of 6 or 7 hours relief? So I'll use the longer acting one. Now, it's said that if you're going to use bupivacaine, you need to be a little more patient in waiting to do your procedures because it takes a little longer to set up, like 5 or 6 minutes more than lidocaine. That's okay. I don't mind that. But to give the patient 6, 7 hours of pain relief, I think that's worth it. Here we're seeing a transthecal nerve block. And even just looking at that, I get a little uncomfortable. It's actually a very easy nerve block to do. The stakes are a little bit higher if you're going to go there because you got to check before you inject. You want to aspirate because you don't want to be injecting directly into either of the palmar arches. That wouldn't go well for you. But generally speaking, the palmar arches are proximal to where the finger is in that picture. So you're okay. And then sometimes it's a little bit hard to convince the patient that you should be able to stick a needle through the thicker skin on their palm. So if you can do a little transcutaneous numbing there, that might help you as well. Or a little spray with your ethylene chloride or whatever it is that's going to allow you to get through their palm. Here you see a web space injection. That'll get both sides. As shown there, it'll get the radial side of the long digit and the ulnar side of the index. Complications, they talk about infection. That's really not a big issue. Obviously, you ought to do them with sterile technique. Try to avoid going through an abscess. I think that makes sense. Hematomas, they can occur, but they're usually not a big deal. You want to avoid the digital nerve or digital arteries when you're doing these. And you want to do intermittent aspiration to make sure you're not injecting directly into an artery. Gangrene from epinephrine. This myth has been debunked a million times. There are dozens of papers now that say you'll get away with using lidocaine with epi on the hand and fingers regularly. So there's lots of literature on it. There's even a best evidence topics report and a Cochrane report saying that this thing about using epinephrine causing the fingers to fall off is largely a myth. Having noted that, do I use epinephrine? No, I use the plain most of the time. But if I have someone bleeding like stink, I might use some epi to try and control it a little bit. And then nerve injury, pretty rare, but theoretically your needle, the bevel edge of your needle could lacerate a digital nerve, which would not be good. So every once in a while I'll see an inexperienced resident sort of fishing around in there like this, like they're trying to saw through it. I'm like, what are you doing? That's not, there's a sharp edge in there. Please don't, do injury to the patient while you're doing this. And we were 1 minute over. Thank you very much. I know that was a bit of a blitzkrieg.